I am your host, Dr. Jack Braha, and welcome to the Medcastplus show. On this show, I will feature local healthcare providers to share their experiences and help educate us on different topics related to our well-being. You can view previous episodes on the web, and we welcome you to visit our website at medcastplus.com. Today, my guest is Dr. Krishna Guram. Dr. Guram is a gastroenterologist here in Brooklyn. I am so happy to have another gastro on the show today. Welcome, Dr. Guram, to the show.
Thank you very much. It's a pleasure to be here, and anything I can do for the community, I'm here for them.
Well, that's the whole point of our show here, is really to educate our community at large about different healthcare topics. And gastroenterology has got to be one of the most common complaints when folks walk into the doctor's office, whether it's gas or bloat. They're worried about colon cancer, heartburn, and reflux. These are very, very common things. And so to have you on the show today is really an honor because you're a fellow Brooklyn gastroenterologist. Tell me, how do you like Brooklyn?
Brooklyn's great. You know, I grew up all over. I'm from Indiana. So when I come from Indiana to New York, it's a big change.
Well, there's less parking, right?
Less parking, yes. That's for sure. A lot more high-rises, no farmland.
No farmland, less parking. And because of the absence of parking and the presence of traffic, we get a lot more business, I think, in gastroenterology because people get an upset stomach and some heartburn while they're driving around our great city here. So you're in Brooklyn. Where are you working now in Brooklyn?
So I'm at the Brooklyn Hospital. I'm the associate program director there for gastroenterology. I do interventional gastroenterology, which is more for the advanced endoscopy stuff. I did my transplant hepatology, which means pre and post liver transplant patients. I take care of them. So we try to give them a good spectrum of GI healthcare there.
Yeah, so what Dr. Guram is explaining here is that he has trained extensively in gastroenterology. How many years of training does it take to become a gastroenterologist? Tell our viewers today how long the road is.
Well, it depends on if you really had to have a passion for it. As usual, you have to go to med school for 4 years. You got to do 3 years of internal medicine residency. I did 2 years of transplant hepatology because I really thought I wanted to be more of an for a liver transplant. Did 3 years of GI, gastroenterology, and another year of advanced. So if you add that.
Now Dr. Guram is 85 years old and a well-trained gastroenterologist. I got to tell you that my favorite part of my training in gastroenterology was doing transplant, and I was very lucky to be at Mount Sinai in Manhattan to do transplant. Where did you do your transplant training?
I did in University of Toronto. At that point, I wanted to do a lot more of living donor liver transplant evaluation and everything, and that kind of led me to that center. So it was a great experience, and again, it's different than Indiana, of course, in Toronto, but it has a lot of similarities to New York. So
yeah. Transplant to me is one of the most fascinating parts, and what Dr. Guram is explaining about living donor is where a person who is alive donates a part of their liver as opposed to deceased cadaveric donations where after someone passes, they choose to donate their organs. So it's an incredible thing. Now, liver transplant is a little bit less common than some of the disorders we're going to talk about today. Let's start our talk today a little bit about something that I see every day in my practice, and I'm sure that you do, heartburn, reflux disease.
That's right.
Explain to our viewers a little bit, what is heartburn?
Well, whenever you eat out or eat late and have extra hot sauce or something, you feel this little burning that occurs in your chest. And then you take some Tums and it goes away. That's basically what it is. It feels like it's in your chest and it's burning, and that's basically heartburn. And it's the most common GI side effect or symptom that people have and treat for.
I see it every day. Every day when I'm in the office, someone comes in and says, I have chest pain, which always worries me because you have to differentiate between a heart attack or some other catastrophic problem in the chest versus heartburn, right?
Definitely.
What are some of the features that you look for to say, hey, this is a guy or a gal that's got to be sent over to the ER when they're having this burn in the chest?
So, again, as you clearly mentioned, cardiac disease or heart disease is the first thing you got to think about. And it also depends on age. So if you get a younger person saying it's heartburn, it's less likely heart-related thing. But when you get an older gentleman in the 40s, 50s, and having this, you have to really differentiate that. If I see a person saying they're having more of a pressure and something going down their arm, or they feel very sweaty and they have shortness of breath, that's not really heartburn. They might have symptoms of heartburn at that time, which kind of mimics what it is, but that's something to get more concerned about.
Right, that's really important for our viewers to know that not every burn in the chest is because you ate a taco an hour ago. It could actually be serious. And so what I always explain, or what I ask to the patients, is what you're describing. Do you get sweaty when this occurs? Or actually, one of the biggest questions I ask is, when you go up and down steps or you're exercising, does that bring back your heartburn, which we know is not really heartburn at that time? That's heart disease. So that's important for our viewers. Once you're able to say, hey, listen, I know that this is heartburn, GERD, gastroesophageal reflux disease, and it's not cardiac disease, how do you start off with counseling and treating the patient for this?
The most important thing is lifestyle modification, right? Just the things that they probably felt before, they're like, oh, I ate something bad. Those are all really related to their reflux. Now, whenever we have this reflux, it's a lack of or a little relaxation of the sphincter, which covers our food pipe to our stomach. It's that right in that area. And it relaxes and you get reflux at that time.
This is the valve that keeps our esophagus closed. Right.
Yep.
And so when this relaxes a little bit too often or too much,
then you get that reflux.
Here we go again, right.
Yep.
So what do you do about diet? What's your recommendations?
So most important thing, eat early, at least, especially before dinner or so. Give 3 to 4 hours so that your stomach is not full, and then you go to bed and then you get reflux. You want at least 3 to 4 hours because that's what it takes to empty out. Then, of course, then the fun stuff comes in. Chocolate. If you love chocolate, well, that relaxes that sphincter again. You want
the chemicals in chocolate.
Exactly.
Sometimes the caffeine.
The caffeine
right?
from coffee, alcohol. So all the goodies we want to enjoy a little bit later in the evening or have fun can all make the symptoms of reflux worse.
Right, isn't there, what's that chocolate, like after 8 or after 10, or I don't know what it's called in the supermarket I see sometimes, where it's chocolate and mint together.
Mint together.
And that's the devil for
That
us.
That is, especially if you have peppermint. That's another thing that relaxes everything and you get reflux. So maybe not the best choice.
Right, so when I see the patients in the office, I ask them, well, what time do you eat dinner? And you mentioned this about how long does it take for the stomach to empty. And that's a really important thing to educate patients on, and for our viewers today, is that, listen, the stomach, when you eat your meal, doesn't empty immediately. And so when they get home at night, I do exactly what you're saying. Eat early. I ask that they walk around also to try to empty the stomach. What about when they get into bed?
So if you're still having symptoms and you waited 3-4 hours, but you're still having some reflux, naturally we tend to have more reflux at night because there's no gravity. We're just lying flat. So sometimes I tell them you can put an extra pillow in there, or if it's getting bad, put a wedge so that it lifts the bed up a little bit, or you can lie back where you're not fully flat, and that prevents that acid from reflux.
Raising that area to draw the acid or the reflux back down into the stomach is
exactly.
important.
Yeah.
So say I'm your patient. I pretended maybe to listen to your dietary suggestions. I eliminated my coffee. I eliminated the peppermint I eat at night. I got rid of the chocolate milkshake I have every day, and I'm still having heartburn. What are the other things in my life that could be causing or making my heartburn worse?
Well, I think stress definitely has that. I mean, we know stress makes a huge impact in whatever we are. Whenever we're in stress, we have even sometimes diarrhea, sometimes heartburn, and everything else. But I think the next thing is, if everything you're doing and you're really sticking to it is not really working, then you got to think about, well, what other medications can I take to help my symptoms?
Yeah, there are medical treatments. We always, in my practice at least, I try, and I see that you probably do the same, to counsel patients about how to change their life. They can easily fix heartburn by diet, losing weight. We should talk about that a little bit. We know that the waist size, right? As waist size goes up,
they get more reflux.
They get more reflux. So I try to counsel on diet and exercise. You mentioned some medications. Let's talk about these medications. What are you using? What type of drugs can we use for heartburn symptoms?
So if it's once in a while, I usually say, well, take some luminal antacids. What that means is acid, when acid is there, you give something, it mixes with it, takes the acid away. So that's where you start using Tums, Mylanta. I try to stay away from Tums. I know they say calcium is good for you, but I know calcium sometimes gets the acid reflux back a little bit later, so that's still good if you need it at that point. Now let's just say that once in a while is becoming a little bit more often and you don't want to pop pills or drink something every time. The other thing that I try to do is start with other medications that are over the counter like Zantac and Prilosec, which suppresses the acid to a level. But know that if you keep using that often as well, it won't last. Your body gets used to it and you get sometimes more of a response of more acid.
Right, so these medicines, like what are known as H2RA blockers, histamine 2 receptor blockers, decrease acid. They were one of the first drugs that were game changers decades ago, when I guess you and I were babies at this point.
Yes.
But then the next class of drugs, the PPIs, which we all hear about on TV, they're on the news quite a bit, there are plenty of advertisements, like Nexium, other medications like that, they really get the acid level down.
That is the gold, I guess, the standard of treatment for any acid. I mean, if they're not working, you got to really think twice, why aren't they working? These things really shut down the acid pump and they calm everything down. I mean, after, like you're saying, when we started having the H2 blockers and the PPIs, before they were doing surgeries for ulcers and everything.
Yeah.
Now with these medications, those surgeries for ulcers have disappeared.
They are rarely, if ever, done.
Yep.
I think back in the 80s and in the 70s, they were done quite more frequently. Yep. When you talk to surgeons who have a little more experience under their belt, they used to do these all week long, many, many cases. Yep. Thank God for these drugs, because patients don't have to go into the knife. Beyond the medications, beyond the lifestyle changes, you know, as gastroenterologists, we do endoscopies. Yep. These are little camera tests that we do when the patient's sedated, take only a few minutes. When do you make that decision to do an upper endoscopy on a patient with GERD?